Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, we shall learn how to properly interpret the complete blood count, a laboratory test we physicians commonly request. This session will be presented by Dr. Joy Ann V. De Castro, a practicing adult hematologist at Bacolod City, Negros Occidental, and a graduate of Clinical Hematology Fellowship Training Program of the University of Santo Tomas Hospital, and was awarded as the Most Outstanding Graduating Fellow last 2019. She is also an awardee by the American Society of Hematology Visitor Training Program last 2019 to the Institute for Immunology and Transfusion Medicine at the University of Greifswald, Germany. This session will be moderated by Dr. Jacqueline Arsenal.
Good afternoon, everyone. First, I would like to congratulate Tiger for its first postgraduate course, and would also express my gratitude for inviting me to speak on the basics and case-based interpretation of hemogram, aka CBC, for the next 25 minutes. Full credits to my family in the section of clinical hematology for 100% helping me out with this presentation. Deciphering a complete blood count. We all know that a CBC is a routine test that evaluates three major components of the blood: the RBCs, the leukocytes, and the thrombocytes. It measures the amount of each blood component, and it's used to determine many abnormalities with either production or destruction of blood cells. In automated counters, the principle of cell counting is based on electrical pulse generated by each cell as it passes through a small aperture surrounded by electrodes. This counter not only registers the total cell count, but also estimates the average cell volume and variation in the cell sizes. This table shows the normal range of CBC as adopted from the Mayo Clinic. Note that there may be variations in the normal values depending on the ethnicity of the patient, especially on the WBC count. As mentioned, its components cover the red cell parameters, which include the hemoglobin, the hematocrit, which is the fractional volume of blood occupied by erythrocytes, which is calculated from the product of direct measurements of the erythrocyte count and the MCV, and the red cell indices, the MCV, the MCH, which reflect the size and the hemoglobin content of erythrocytes, aiding in the diagnostic workup of anemia, and the RDW, or the red cell distribution read, which estimates the variation in the volume within the population of red cells. This can be used as a red flag to select those samples that should have manual review of blood cells for cell morphology. To make things easier to grasp, let us have some applications. We have prepared here three cases for you. First, we have a 30-year-old female who came in due to dizziness. She has a 3-month history of menometrorrhagia, uses 3 soaked diapers per day, each cycle lasting for 6 to 7 days, and complained 2 weeks prior, started headache and dizziness. She didn't have any pregnancy in the past. Her past medical history is non-contributory, and her mother claims to have anemia. Physical examination revealed a tachycardic patient, with pale palpebrae and anecteric sclerae without any palpable organomegaly. The attending physician requested for a CBC and whole abdomen ultrasound, as well as gynecologic consult. The question is, what initial diagnostic tests will you request? Will it be iron studies and reticulocyte count? Will it be fecal occult blood test, bone marrow aspiration and biopsy, or, as mentioned, the whole abdomen ultrasound? This is the patient's CBC. Now, how do we approach these results in relation to the history and PE findings? Since she presented with symptoms relating to anemia secondary to blood loss, the first parameter to check is the hemoglobin level. According to the World Health Organization guidelines for non-pregnant menstruating women, the normal hemoglobin is 120 and above. 110 to 119 is classified as mild anemia, 80 to 109 is moderate, and any value below 80 is considered as severe anemia. Based on the result, the patient obviously has severe anemia. Next, we look at the red cell indices, which will give us an idea of the possible cause of anemia. Any value below the normal levels of the indices indicates microcytic hypochromic red cells. Results above the normal value indicates macrocytic and hypochromic ones, and in between are normocytic and normocytic red cells. With the red cell indices, we can already come up with several differential diagnoses for our case. Now, for this 30-year-old female patient, she has hypochromia and microcytosis. And upon further dissection of her hemogram, she also has elevated RDW and reactive thrombocytosis, narrowing our impression to a more likely iron deficiency anemia, especially in a setting of significant blood loss. The following slides will show us diagnostic algorithm and how to work patient up if one has microcytic anemia, of which two most commonly seen in practice is iron deficiency and hemoglobinopathies in the form of thalassemia. Another algorithm for normocytic anemia, which could be of various underlying causes, and macrocytic anemia, which can be secondary to chronic medication, nutritional deficiency, or a clue to a beginning true or primary bone marrow disorder. In anemic patients, a single simple test that plays a pivotal role in determining the possible etiology of anemia is the reticulocyte count. Reticulocytes are immature red cells produced in the bone marrow and released in the circulation to mature in 1 to 2 days. An increase or decrease in the reticulocyte count can be a marker of erythropoiesis activity or failure with respect to the patient's degree of anemia. It can be appreciated under the microscope after supravital staining as red cells with intracellular inclusions representing remnants of RNA. Our case has reticulocytopenia of 0.5%. Additional workup included iron studies. We have a ferritin of 11, which is low, serum iron of 10.7, TIBC of 56, and computed transferrin saturation of 18.87%. With these results, we can zoom in our diagnosis to severe IDA. This is a peripheral blood smear of a patient with iron deficiency anemia. Normal lymphocyte for comparison purposes is seen at the edge of the smear. Significant hypochromia and microcytosis, as well as moderate variation in size and shape of the red cells or anisopoikilocytosis is also evident. So most likely IDA severe due to blood loss. Opposite of anemia is now erythrocytosis or polycythemia. Polycythemia vera is a disease entity which is described as an increase in the red cell mass, not driven by erythropoietin. It's actually a true or a clonal myeloproliferative disorder. The patient should be able to fulfill all three major criteria or two major and a minor criteria with the following details. Hemoglobin of 16.5 grams per DL in men, or 16 grams per DL in women, or a hematocrit of 49% in males and 48% in women, or increase on the red cell mass. Another major criterion is BMA showing panmyelosis. And another one is the presence of JAK2 mutation in the blood or in the sample from the bone marrow. The minor criteria include a subnormal erythropoietin levels. This slide shows an algorithm on how to approach a patient with erythrocytosis, starting off with screening serum erythropoietin levels. Now, we proceed with our second case. We have a 70-year-old male with 2 months history of fatigue and 10-pound weight loss associated with generalized weakness. He has no comorbidities, no previous surgeries, no recent infection, and as well a non-smoker and non-alcoholic beverage drinker. His physical examination shows a pale palpebra with a palpable spleen 4 cms below the left costal margin. His CBC is as follows. He has a hemoglobin level of 13, a normal platelet of 216, and leukocytosis with the following differential counts. It's seemingly that this patient is having all types of cells as reflected in his differential count. So that's showing all stages of maturation in correlation with his bone marrow. Now, what test shall we request this 70-year-old male? 1, shall we request for bone marrow aspiration biopsy? 2, peripheral blood smear? 3, leukocyte antigen phosphatase score? Or D, procalcitonin levels? In cases like this, we have to establish or confirm the presence of immature white cells in the PBS, especially in patients with unexplained leukocytosis. WBC typically seen in the blood film include neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Immature granulocytes from blasts to metamyelocytes in the PBS are abnormal findings. So this figure is a peripheral blood smear. Note that there are spectrum of maturation within the myeloid cell lines, including the immature forms of blasts, pointed by the red arrow, the mid-stage myeloids to the myelocytes, pointed by the blue arrows, and the late-stage myeloids, neutrophils, and band forms, as pointed by the black arrows. A basophil is also present, marked by the star. These features are typical of CML. Based on the patient's history and lab results, how will we approach this case? This is a busy algorithm from ASH, or American Society of Hematology, on how to approach leukocytosis. Everything must be interpreted in proper clinical context. And very important, we have to confirm if the leukocytosis is of benign or reactive, or may it be malignant in nature. Additional workup for this elderly male's leukocytosis included a bone marrow aspiration and core biopsy, revealing a markedly hypercellular marrow. Remember, this is a 70-year-old male. Granulocytic hyperplasia with progressive, showing all stages of maturation, and relative erythroid hypoplasia with small hypolobated megakaryocytes termed as dwarf megs. So it's as if there are small megs in a sea of granulocytes. Further, somehow sophisticated tests. On the left is the results of conventional karyotyping, showing the classic translocation 922 between the long arms of chromosomes 9 and 22, which characterizes chronic myeloid leukemia. Arrows represent the abnormal derivative chromosomes resulting from this apparently balanced translocation. Figure on the right is the dual fusion FISH, or fluorescence in situ hybridization in CML. The ABL1 gene on chromosome 9 is marked in red, and the BCR gene on chromosome 22 is marked green. A normal diploid cell should have 2 red signals and 2 green signals, that is 2 copies of each gene. In CML, you typically see 1 red and 1 green, and 2 yellow signals, meaning that the 2 genes are close enough such that the red and the green signals fuse into a yellow signal. So the final diagnosis for this case number 2 is CML in chronic phase, and the treatment includes starting patients on tyrosine kinase inhibitor with response assessment done through QRT-PCR for BCR-ABL. On the other hand, there is leukopenia, or decrease in the leukocyte count. May it be neutropenia or lymphopenia. So neutropenia, severe neutropenia, has a computed ANC of less than 500, making the patient of highest risk of recurrent infection. It could be secondary from a congenital form or an acquired form. So usually more common or most common acquired forms come from infection or drug-induced, in which the table on the left enumerates some of the drugs that are common culprits for leukopenia or neutropenia. Lymphopenia, on the other hand, is defined as total lymphocyte count of less than 1, or in some books 1.5, which is most of the time a result of recent therapy with immunosuppressive drugs, sometimes also glucocorticoids. Some patients having a clue to an underlying connective tissue disease and immunodeficiencies. So now it's also implicated or of clinical value for patients with COVID infection. Immunology consult is advised, especially if the patient has clues for congenital lymphopenia being suspected. Our last case is that of a 49-year-old female who is referred for evaluation of elevated platelet count incidentally found out from a preoperative CBC. Patient has a 1-year history of enlarging intracranial mass, and she is planned for stereotactic guided biopsy. Elevated platelet count was noted since 1 year prior to consult. Her review of system has no B symptoms. She has no comorbidities nor maintenance medications, with unremarkable family history. Physical examination is otherwise non-contributory, and her CBC is as follows. She has a normal hemoglobin, mild leukocytosis of neutrophilic predominance, and an elevated platelet count of 920 with whitened MPV. What workups or what diagnostics will you request for this particular patient? Shall you request for a repeat CBC? Shall we do an ESR or CRP? Shall we perform peripheral blood smear or proceed immediately to JAK2 mutation assay? Thrombocytosis, platelet counts above 450, may represent either a myeloid malignancy or secondary process related to various clinical conditions, including iron deficiency anemia, surgical asplenia, infection, chronic inflammation, hemolysis, or tissue damage. It is important to distinguish between a primary thrombocytosis from reactive thrombocytosis, because the former is associated with increased risk of thrombohemorrhagic complications. Initial lab tests in the absence of clinical evidence for RT should include PBS, serum ferritin, and CRP. Platelet morphology, as we examine the peripheral blood smear, is usually normal in reactive thrombocytosis. A measurement of our inflammatory markers, such as your CRP and ESR, is helpful in examining the possibility of an occult inflammatory process or a malignant process as a cause of reactive thrombocytosis. If these workups are negative, BMA with cytogenetics and FISH for BCR-ABL, as indicated, can be done, and other molecular markers such as your JAK2 mutation assay, your MPL, and your calreticulin may be done to determine the presence of an underlying myeloproliferative neoplasm or myeloproliferative disorder. So this table, taken from the New England Journal of Medicine, puts a line between a clonal thrombocytosis and reactive thrombocytosis. Our 49-year-old female patient's further workup showed a normal ESR, as well as CRP, and a negative JAK2 mutation assay. Her PBS shows a wide variations in the size and the shape of the platelets, and her bone marrow biopsy shows hypercellular for her age with increased number of megakaryocytes. The megakaryocytes are dispersed throughout the marrow and include frequent large forms with abundant cytoplasm and deeply lobated nuclei. Thus, this patient was signed out as a case of myeloproliferative neoplasm, most likely essential thrombocythemia, and was managed by starting hydroxyurea 3 times a day and aspirin as prophylaxis to prevent problematic thrombotic events in the future. This is the criteria for the diagnosis of essential thrombocythemia or essential thrombocytosis lifted from the latest edition of NCCN. So we have to meet all four major criteria in the first three major criteria with the one minor criterion. Antonym of elevated platelets, we have thrombocytopenia. Any values below 150 is considered thrombocytopenic. So first, we have to review the peripheral blood to confirm if it's really thrombocytopenia, because we have to check on cases of pseudothrombocytopenia, secondary to platelet satellitism. Platelets adhere in these cases to cytoplasmic membrane of two polymorphonuclears present on the peripheral blood smear. This phenomenon is actually just an in vitro artifact that occurs with EGTA anticoagulation. Collection of blood via citrate or heparin can resolve this issue. We have also to check on the peripheral blood smear just to check if there are other underlying causes of thrombocytopenia that require immediate therapy, such as your TTP or your thrombotic thrombocytopenic purpura or your HUS. And of course, medication history should always be reviewed. So this thrombocytopenia algorithm, as what I've mentioned from the previous slide, we have to check on the PPS if there is indeed thrombocytopenia and presence of significant amount of fragmented RBCs or schistocytes. This, with elevated LDH level and decreased haptoglobin level, would point out to a possible diagnosis of TTP in the HUS and warrants a hematologic consultation or hematologic co-management. There are a battery of culprits for acute onset thrombocytopenia aside from infection. Amongst the most common reasons are medications or drugs through the following mechanisms. Drug-associated immune-mediated thrombocytopenia and HIT, which is HIT meaning the heparin-induced thrombocytopenia, which is actually of high risk of thrombosis rather than bleeding. This is the 4T scoring system to evaluate the pretest risk of a patient likely or not likely to be experiencing or to be having HIT. So this is my last slide with the references from which the bulk of information in the presentation were taken from. Thank you very much.
For this breakout session, we will learn the basics of interpreting the urinalysis with Dr. Melvin Marcial, an associate professor of the Department of Medicine at the University of Santo Tomas Faculty of Medicine and Surgery. He is also a published author of 2 books, The Comprehensive Guide to Physical Examination and The Atlas of Urinary Sediments. He is also a member of the Philippine Specialty Board in Internal Medicine. This session will be moderated by Dr. Jacqueline Arsenal.
Hi, this is Dr. Melvin Marcial. I will be talking to you about urinalysis, the peace prophet. In clinical practice, a case-based learning. So the pictures from this lecture will be derived from our book, Daisog's Atlas of Urine Sediments, together with my professor, Alberto Daisog, and Dr. Moral. It was published by Anvil last 2001. So the following are learning outcomes. First is to be knowledgeable with the proper collection of urine specimen. Second, to discriminate between a normal and an abnormal urinalysis. Third, to distinguish between a contaminated and an abnormal urinalysis. Fourth, to identify urinalysis findings in common renal diseases. And 5, to establish diagnosis based on urinalysis. So you see very well that urinalysis will depend on how good the specimen collection is. So male and female in general, in summary, it should be spontaneously voided and it should be clean cut urine, midstream clean cut urine. But the details of which will be the urine specimen must be properly collected to reliably interpret the findings and to maximize diagnostic utility. The techniques to be followed whenever feasible, the specimen should be collected into a clean, dry container. Patients should be asked to clean the external genitalia as shown in the picture, provide a midstream specimen for analysis of a spontaneously voided urine. And in patients with indwelling urinary catheters, recently produced urine sample should be obtained. That is directly from the catheter tubing and not from the drain bag. And to ensure that the sample represents recently produced urine and to avoid contamination of the sample by the debris in the collection bag. And in the specimen handling, it should be examined at room temperature, hopefully within an hour or two of retrieval. However, if it is not feasible, the sample should be refrigerated at least 2 to 8 degrees Celsius and then rewarmed to room temperature prior to assessment. So this is the picture. Kindly take note of this. Whether it's a male or a female, it should be properly collected and midstream touch. Okay. So as a nephrologist, I have made my own guideline when examining a urinalysis result. So not all urinalyses are created or formulated equal or read equally. So for me as a nephrologist and even a non-nephrologist will be guided by these guidelines that I made. First and foremost, you should ask when you see a urinalysis, is the urinalysis an acceptable specimen to begin with or is it contaminated? Second, is the urinalysis normal or abnormal? You should ask yourself that question. Third, identify what component of the urinalysis is abnormal. Fourth, are the findings clinically compatible with the patient's presentation? Next, is there any component of the urinalysis not reported and needs to be requested or repeated? Next, any additional information needed to be asked from the patient? What possible additional laboratories and ancillary procedures to be done to confirm your clinical impression? And last, and the most important, can you have a clinical impression based on the urinalysis findings alone? So I hope these guidelines will be able to help you in examining a urinalysis result. So every case, I have prepared at least 8 cases for you. Actually, there are so many cases to tackle. However, due to time constraint, I will just be tackling about 8 cases, but you can ask me later for other cases that you want me to discuss. So every case that I will present will use these guidelines when answering about the urinalysis result. So this is the first case, doctors. This is a the cases that I included are very common cases encountered by a general physician. So this one, the case one, a 60-year-old female, diabetic, hypertensive, on her regular follow-up, though asymptomatic, as the following urinalysis findings. You see here, this is the urinalysis, and I have highlighted for you all those abnormal that we think that is abnormal, highlighted in red. The color is dark yellow, turbid. Reaction is 6.5 pH. Then 3 plus protein. Nitrite is positive. Leukocyte 3 plus. And then white blood cell, which is usually your attention will be drawn into 51 to 75 per high power field. Red blood cell 1 to 3. And then there are so many squamous cells, 60 per high power field, many. And bacteria is about 0 to 10, and amorphous urate is many. So what do you think of this urinalysis? So let us use the guideline that I have made. I have pasted the urinalysis result on the left, and on the right is the guideline. So remember, our patient is a 60-year-old female, diabetic, hypertensive, but asymptomatic, but presenting to you with this kind of urinalysis. So what do you think, doctors, of this case? First, is the urinalysis an acceptable specimen to begin with? Is the urinalysis normal or abnormal? Identify what component of the urinalysis is abnormal. These are the findings clinically compatible. Is there any component of the urinalysis not reported that needs to be reported or requested or repeated? Any additional information needed to be asked from the patient? What possible additional labs to be done to confirm the impression? And what is your clinical impression based on the urinalysis alone? So let me answer it one by one. Okay, so let's see. So this is the answer. Let's see whether are you given much time, doctors? Are you given much time to think about the answers for this? I'll give you some seconds for it, but let's see. So this is the answer for the case one. Is the urinalysis an acceptable specimen to begin with or contaminated? Is it acceptable for us? Definitely, it is not acceptable. Why? We will answer it later. Okay. But what do you think is the cause of being not being acceptable, doctors? Second, is the urinalysis normal or abnormal? Definitely, it is not normal. And here, what are the components of the urinalysis that is abnormal? First and foremost, you can see here that there's a 3 plus proteinuria, there's a positive nitrite, positive leukocyte esterase test, the urea is significant, 51 to 75. The squamous cells are very much increased. Then there are many amorphous urine. Then the next question is the findings clinically compatible? Definitely not. Though the patient on her routine follow-up is asymptomatic, but when you see this urinalysis, you think first whether this patient is having some symptoms or not, fever, dysuria, etc., but there's none. And then, is there any component of the urinalysis not reported and needs to be requested or repeated? Definitely, we should be able to repeat the urinalysis that is properly collected in order to assess the real urinalysis status of this patient. And any additional information needed to be asked from the patient? Yes, there is. The manner of collection. How was the urine collected? And upon further questioning of this patient, it was not midstream and it is not also clean catch. She collected the urine at home and traveled 2 hours to lab. So before the urinalysis was examined, it was more than 2 hours. And then what possible additional laboratories? Definitely just a repeat urinalysis. And can you make a clinical impression? Definitely yes, that it is an improperly collected urine because of the many squamous cells in this patient. No, 60 per high power field, which is unacceptable for us. Definitely, it was not midstream. Therefore, we are not warranted to give antibiotics in this patient because there's no UTI or urinary tract infection. And despite having a pyuria, positive nitrite test, positive leukocyte esterase test, there's no basis for us in giving antibiotics. Unfortunately, in real setting, most of these patients will be given antibiotics because of the prominent pyuria, but they did not examine well the urinalysis. Okay, so I hope you were able to um, to understand this case number one. Let's go to case number two. So before going to case number two, this is the example of the squamous epithelial cell that you can see when you personally look at the urinalysis. This is from the Dyson's Atlas of Urine Sediment. Okay, so next will be case number two. There's a 33-year-old female call center agent on annual medical examination and has the following urinalysis findings. So this one, it was yellow, slightly turbid, negative nitrite, negative leukocyte. Then white blood cell is 1 to 5, red blood cell is 1 to 5. Okay, slightly elevated compared to the normal. And then there's a squamous cell which is only 1 to 3, and there's no significant bacteriuria. Unfortunately, not all urinalysis will have the same kind of reporting. Others will not report either normal or references, but maybe choose a better laboratory to have your urinalysis done. Okay. So now, can we answer now the case number two, whether you can now answer it properly by yourself? Is the urinalysis acceptable? Let's see. So let's go directly to the guidelines, doctors. Here, yes, it is acceptable. Is the urinalysis normal? Definitely yes. Identify what component of urinalysis? None, because the WBC and red blood cell are quite acceptable, even though it is a little higher than normal because the patient also is asymptomatic and there's nothing that we can see. And then is the find is clinically compatible? Yes, patient is asymptomatic. Any component of urinalysis not reported, everything was reported well, so it was acceptable. Any additional information needed to be asked from the patient? I think obviously this patient had a midstream catch, clean catch urine, so there's nothing more, but you can always ask. There's nothing to lose. And then what possible additional laboratories? I think none. By history, if you think that there's no need for other laboratories, then urinalysis will be enough. Can you have clinical impression? Definitely yes. And you can say that it is a properly collected normal urinalysis. Okay. So I hope you were able to compare case 1 to case 2. So case 1 is quite common, doctors, and especially in elderly patients that are having hard time in collecting urine. That's why in some cases, if there's no proper collection, we can advocate a straight catheterization in order for us to have a good specimen. Okay, let's go now to case number 3. Okay, in case number 3, a 25-year-old male seafarer for medical clearance. No, we have seen this with history of passage of stone when he was first year college, no known comorbidity with family history of kidney stones, father and 2 siblings. Physical examination essentially normal, CBC and serum creatinine are within normal limits. Urinalysis findings are followed. Have you experienced this, that this seafarer will go to you for immediate medical clearance and they will ask for immediate clearance from you even though it's only 1 day or 2 days. So here's the urinalysis of that seafarer. It is color red, turbid, then alkalotic urine of 7 on the alkalotic side. Specific gravity is high at 1.025, meaning it's a little bit on the heavy side or dehydrated side. There are 3 plus protein, positive nitrite, positive leukocyte esterase test, and then there was a 3 plus blood, and then there's 10 to 15 WBC count, and then RBC is too numerous to count. Squamous cell is only 1 to 3. Bacteria is about 10 to 20, which is quite high for a male. Okay, so let's see. And then definitely if your patient has a hematuria or a red urine, then the technician or the med tech also take note of the morphology of the RBC, which is isomorphic. So that's very good. Okay, so here, doctor is the guideline. Can we answer it now by showing this? Will you be that confident in answering this guideline? Okay, I'll give you some time to answer it. Okay, let's go now to the guideline. So, is the urinalysis an acceptable specimen to begin with or contaminated? Definitely it is acceptable. Okay, so you have seen here that it is nothing here that will tell us that it is not properly collected. The squamous cell are okay, but in male usually there's no problem with collection. Okay, is the urinalysis normal or abnormal? Obviously, it is abnormal. And what are the things that are abnormal? First, the 7 pH in the urine is somewhat alkalotic. Usually, the usual urine should be less than 5.5, okay, to make it more acidic. But if it is an alkalotic side, 7, then there's something wrong, maybe, okay? Then the positive nitrite, positive leukocyte, meaning positive nitrite means there's a conversion from the nitrate to nitrite in your patient that is seen in a patient with infection. And then leukocyte esterase test is positive. Leukocyte esterase test does not really mean infection, but there's a conversion of the leukocyte esterase by the presence of the white blood cells in the urine. And then there's pyuria, which is 10 to 15, and then the hematuria, which cannot be counted. That's too numerous to count. But take note, the morphology of the RBC is isomorphic, so definitely it is non-glomerular. And then there's a top normal bacteriuria, proteinuria due to WBC. So here maybe we can attribute that the proteinuria, the 3 plus, is maybe due to the WBC and the numerous RBC that is present. And then the specific gravity is top normal, maybe because of dehydration. And especially there's also the presence of hyaline cast. Have you noticed on the upper right side? And definitely, if it is an alkalotic urine, doctors, and this patient is dehydrated, this patient and a history, positive history of stone, this patient has a positive predisposition to calcium stone formation. And then, are there any findings clinically compatible? Yes, by history, family history, possible recent stone passage. Though the patient may not be complaining anything, especially seafarers, they will just deny everything. Definitely, there's an evidence that there might be some recent stone passage because of the gross, the microscopic hematuria in this patient. Any component of the urinalysis not reported? None. Any additional information? Definitely the dietary habit. If this patient is a seafarer, most likely they're eating food that is high in protein, like for example the red meat, also uh, innards, no, mga laman loob, and also vitamin C. You see, vitamin C predisposes one, especially mega doses of vitamin C, predisposes one to produce calcium oxalate stone. So they thought that vitamin C is very protective, but it has some um, a disadvantage of having some kidney stones. And then definitely the hydration status. What possible additional laboratories? Then you should request for urine culture, ultrasound of the KUB, or better will be the CT stonogram. Then serum calcium, serum uric acid, urine studies for calcium citrate and uric acid, but it may or may not be because it is quite expensive. And what will be your clinical impression based on this? Yes, definitely there's a urinary tract infection to rule out stone recurrence or recent passage. Okay, so by just urinalysis alone and the history of the patient, you can definitely diagnose this. Next, so this is the picture of a patient with an isomorphic red blood cell. You see, they are all the same looking dumbbell shape. No, if it is a isomorphic, if it is a bleeding, okay, not that is non-glomerular. Then this one, case number 4, there's another seafarer, 25-year-old for medical clearance due to persistent hematuria. There's no significant medical history. He denies everything. No known comorbidity, family history is unremarkable. Physical examination, normal, CBC scan, normal. Workup done by urologist. Actually, he was seen already by urologist post histoscopy, but negative. Did not see anything. Pero in the urinalysis, there's persistent hematuria. No demonstrable kidney stones in CT stonogram. Okay. Usually, doctors initially screening will be ultrasound, but if it is not seen, then CT stonogram will be definitive. Then this is the urinalysis finding of the seafarer. What can you see here is a light red, turbid, then reaction is alkalotic then highly high specific gravity, negative nitrite, leukocyte. There's a microscopic hematuria, 10 to 15, with minimal white blood cell. There's no squamous cell. Hyaline cast, there's high, so quite dehydrated. Bacteria, not significant. And then morphology of RBC is isomorphic. So what do you think is the problem with this patient? How would you resolve the persistent microscopic hematuria despite all the negative workup, even histoscopy? So let's see. So is the urinalysis an acceptable specimen to begin with or contaminated? Acceptable, definitely. The urinalysis is definitely abnormal. There's an alkalotic urine and there's a microscopic hematuria which is isomorphic. And the clinical findings is not clinically compatible because the seafarer says he does not feel anything. Then, is there any component of urinalysis not reported? Everything is reported. Then, additional information, definitely dietary habits, vitamin C again, and then hydration status. Then, what possible additional laboratories? You see, doctors, in this case, we can request for serum calcium, serum uric acid, urine studies for calcium, cited in uric acid. It turned out that there's an increased 24-hour urinary calcium. So what is our impression here? Maybe this patient, though it is not presenting with kidney stones, obviously, but there might be an asymptomatic hypercalciuria. The hypercalciuria can precipitate some persistent microscopic hematuria in this case. So definitely, maybe we can encourage hydration in this patient and also monitor this patient well. But as long as the blood pressure, creatinine, and the proteinuria is not significant in this patient, there is no problem. So this will be labeled as a symptomatic urinary abnormality. Maybe most likely the cause of the persistent microscopic hematuria will be a symptomatic hypercalciuria. Okay, next case. So this is the isomorphic that I've been telling you, morphology. Next case will be a seafarer again. Kasi di ba ito yung laging nagpapa-clearance sa atin, nagpapakonsulta, not known diabetic, not known hypertensive, but recently has a recent headache and nape pain. Blood pressure was 150/90, checked twice. Dati, before he was cleared, it was normal. Now, it was a little bit elevated and noted a Coca-Cola colored urine. No? Parang Coke. Then CBC, serum creatinine, was a little bit high, but still on the high side, but still within normal limits. These are the urinalysis findings. It is light red, turbid, then a little bit alkalotic, then dehydrated, negative nitrate leukocyte. The red blood cell is 10 to 15. In male, actually, we're much stricter than female. And the morphology of the RBC is 60% dysmorphic, meaning it is not isomorphic as we have seen before. And the other, there's hyaline cast and then bacteria is minimal. So let's see for the guidelines. Let's answer, is the urinalysis acceptable, etc. Let's see. Okay, is the urinalysis acceptable specimen to begin with? Yes. Abnormal, definitely abnormal. What are the components of that is abnormal? Light red, proteinuria of 2+, hematuria 60% dysmorphic. When you say dysmorphic, doctors, you will ask me how much dysmorphism will be significant for us to consider some glomerular problem. The answer there's no definite answer, but the higher the percentage of the dysmorphism, the more and more clinically correlated, the more it is important. So the higher the dysmorphism, the more it is more of glomerular in origin. Clinical findings compatible, yes. And then any component of the urinalysis not reported. You see here, there's no report of the RBC cast, which is we should look into it because of the history of what? Headache, elevated blood pressure, high normal creatinine. Any additional lab, then we should have by history when we have asked the seafarer, there was pala a history of sore throat 2 weeks ago. And what possible, now knowing that history, what possible laboratories will you do? Ultrasound of the kidney, ureter, bladder, CBC, creatinine, ASO, and C3. Okay, and maybe ANA, no, maybe do. So what can we see here? That this patient has possibly a post-infectious glomerulonephritis that have caused the elevated blood pressure, gross hematuria, as well as the nape pain and headache in this patient. So you see, doctors, even only with urinalysis and good history taking, we might be able to be led to the correct diagnosis in this case because sometimes they will just give antihypertensive without really identifying the cause of the problem, correlate the hypertension, the nape pain, the headache, and the proteinuria, as well as the discolored urine. Okay, next. So this is the example of your dysmorphic RBC. Unlike the isomorphic, the dysmorphic, because they have passed through the glomerular basement membrane. It is not isomorphic anymore. They are distorted. Okay, so this is the RBC cast, doctors. So when you say RBC cast, it is the tubules that are marked for protein with all the dysmorphic RBC um, inside. Okay, so this is the 18 RBC cast because it's follow one line. This is a thick RBC cast. Okay, so this is a single line RBC cast, doctors. Okay, so case number 6. We have now a 69-year-old male with sudden episode of gross hematuria. No known comorbidity, denies any pain. So it is a painless gross hematuria. It is a painless hematuria. Cannot recall any previous episode of gross hematuria. It's the first time, or no history of stone passage. CBC creatinine are within normal. So this is the urinalysis findings. What is very significant is that it is dark red, turbid. Okay, what else? There's a negative leukocyte. There's a too numerous blood, and then morphology of RBC isomorphic, and also there's no clot in the urine. No, there's no clot in the urinalysis. Okay, so here, so what can we answer? Let's go directly to the guidelines. Is it acceptable? Yes. Abnormal? Yes. Red urine, proteinuria, and hematuria are the one that is abnormal. Are the findings clinically compatible? Yes. No component of the urinalysis not reported. Everything's reported. Then, what should you ask this patient? Definitely history of anorexia, unintentional weight loss. Remember, this is a 69 male with sudden gross hematuria, otherwise asymptomatic. But when upon a history, there was an unintentional weight loss, blood clots in the urine, unlike in other cases that they failed to say, I failed to write the blood clots in the urine. I retract myself there. And then also there's a blood clot in the urine. And then pain during gross hematuria, pero sabi niya, there's none. Okay, so what shall we do? We should do an ultrasound of the kidney and possible cystoscopy. And it turned out that this is a urinary bladder cancer. The blood clot is very important because when you have a blood clot in the urine, meaning it is beyond the kidneys, it is not glomerular. When it is non-clotting, maybe it's most likely coming from the kidneys upper because of the fibrinolytic agents that is still present coming from the glomerulus. But if it is beyond that, then it should be clotting because there's no fibrinolytic agents that is present now in your urine. Okay, so this is a painless gross hematuria, doctors. So it is a urinary bladder cancer. Next, second to the last case, we have now a 30-year-old male with sudden onset of inability to stand up due to weakness of lower extremities. No significant medical history, no known comorbidity, family history, and then markable CBC and creatinine within normal limits. Sodium 140, potassium only 2, urinalysis as finding. So we can see here, doctors, that this yellow, turbid, and then 10 to 15 RBC, squamous cells, 1 to 3, etc. So this is the guideline. We can see here that the urinalysis is acceptable, but it is abnormal, okay, because of the presence of the RBC. And then also what is very important here is the pH of the alkalotic urine, that is more than 5.5, that is 6.5. Low specific gravity, and then the hematuria. And clinically compatible, yes, because this patient has hypokalemia and weakness. So any component of the urinalysis not reported. So this is look intensely for the calcium oxalate crystal. They have missed it because any additional information, previous history of weakness and hypokalemia, precipitating event like stress, high carbohydrate diet, stone passage, thyroid manifestation, and what possible additional laboratory, aside from ultrasound and CT sonogram to look for stones, ABG to look for metabolic acidosis, creatinine, uric acid, calcium, TSH, and FT4. So what is our possible impression here? Maybe renal tubular acidosis, distal or type 1. So here we can catch RTA by just the urinalysis and by history, and ABG as well as the presence of kidney stones. So this is the sample of your calcium oxalate crystals that we should have investigated. Okay, last will be your 65-year-old female for initial consult with gout and hypertension for more than 20 years. No laboratory results available except for urinalysis. So this is the urinalysis. You see here, doctors, what is prominent is the pH is about 7, and then specific gravity is quite on the low side, and then negative nitrite leukocyte, but there's a persistent WBC count, WBC in the urine, and other than that, wala na. You can see here what is our answer for our guideline. Is it acceptable? Yes. Urinalysis normal or abnormal? Definitely it is abnormal. What is abnormal? The alkalotic urine, the low specific gravity, the +1 proteinuria, the leukocyte esterase test, and the pyuria. Is the findings clinically compatible? Yes. Is there any component not done? None. What is additional information? This patient is having some chronic NSAID use. Then there's a polyuria and nocturia at night. That is a symptom of a tubular dysfunction of the kidney. And is there any reason for any UTI symptoms? Why, doctors? Because most likely if another physician will see this, they will just give this patient antibiotics even though this is not warranted. So this patient might be having what? A chronic kidney disease secondary to CTIN, secondary to gouty nephropathy, hypertensive nephrosclerosis. The persistent pyuria here, doctors, is not because of infection, but it's because of the chronic tubular interstitial nephritis. That's the bland urine compared to your DM nephropathy. So you should have done an ultrasound of the kidneys here, AG, CBC, creatinine, sodium, potassium, uric acid, calcium, phosphorus, and FBS. So with that, doctors, that's one lesson here, that you should not give antibiotics when there's an outright WBC in the urine or pyuria, because it might be an interstitial nephritis that is presenting, especially with a history of gout, as well as stones or whatever. No? So don't give antibiotic left and right if it is not warranted. So the summary of cases, doctors, I have presented to you 8 cases. Case 1, improperly collected urine. Case 2, properly collected urine, normal urine. Case 3, renal stones. Case 4, asymptomatic hypercalciuria. Case 5, post-infectious GN. Case 6, urinary bladder CA. Case 7, RTA. And case 8, chronic tubular interstitial nephritis. So I think we have, I hope that we have achieved our learning outcomes of knowledge, to have a knowledge and proper collection of urine, discriminate between normal and abnormal, distinguish between contaminated and abnormal urinalysis, identify urinalysis finding common renal diseases, and establish diagnosis based on urinalysis. With that, I would like to thank you. Okay, thank you very much.
You may now proceed to our Sunset Symposia. Please go to www.tiktok2021.com and click on the room you would like to join.